Today we're going to talk about whiplash injuries and why sometimes the cognitive effects or the brain effects don't go away and what we can do about it.
Stay tuned.
Here on 50 Shades of Pain.
Okay, now stay tuned.
That might have been a mess up, but we'll see.
Technical errors, but it's still good, and we're here for you guys, so no worries.
That's right. So James, what are we talking about today?
All right, so for you guys at home, remember how we've been talking about whiplash injuries, what they do, what they mean, how you can have headaches from them, how you can have neck pain from them, and what to do about each one. But sometimes we're talking about the really bad wrecks. You start to have more issues that are going on. Brain issues, things that seems like a concussion, but it's even worse than that, something like a traumatic brain injury. In those particular cases, you need a little bit more care. We obviously are fantastic at helping out with pain, but sometimes you need something else along with that, and you've got to address the neurosymptoms. So we brought a special guest on to be able to help out with those. So for you at home who have any members of your family, friends that had some sort of brain injury after some sort of whiplash, this show's for you. All right, so we're going to bring our special guest on. Come on over here.
Yay!
All right, cool. All right, tell the crowd who you are.
I'm Heather Cordes, and I work for NeuroRestorative, and we're a post-acute brain injury rehabilitation program. We're in about 26 states now, with over 100 locations within.
Okay, good. So when people have some sort of head injury from a really bad car wreck, they're not really thinking about neuro places like that. They're just thinking about, okay, I just got to go to the ER and I'll be fine, right?
That's correct.
Okay, so why is that a problem?
Well, the problem is the majority of those motor vehicle accidents, what we're looking at is what we would call mild traumatic brain injury. Some of us call it a concussion. Mm-hmm. And we're looking at roughly every 9 seconds, 2.87 million individuals throughout the nation will sustain a traumatic brain injury. 2.5 of that 2.8 are going to be treated and released from the emergency department. And those are representing those, quote, mild TBIs or concussions. Unfortunately, they may not show up on the diagnostic tools, MRIs or CT scans.
All right, so hold on. They go to the ER, they get those amazing scans for their brain, and nothing shows up?
Not really. Not very conducive to that injury, no.
Oh, wow.
A lot of those deep structures. You look at how the brain is moving within the skull when it has that motor vehicle accident. So you want to take that whiplash movement. We call that a coup contre coup. So you're going to get two sites of impact. Usually it's the frontal lobe followed by the occipital lobe. If somebody is struck, obviously from the side, you can get the whiplash movement, and again, a coup contre coup is kind of going from a side to side, and you can have them maybe from a temporal to temporal. Even though that brain is being traumatized and it is being hurt, it still may not be enough to show some of those deeper structures maybe within the brain, how those axons can be stretched, twisted, those types of things.
And axons being like the wiring of the brain.
Correct.
Yeah.
And there might not be a loss of consciousness. Usually there is not. Mild TBI is going to be defined as nothing more than 30 minutes for a loss of consciousness. But you look at, reaching 20 minutes and, when you start getting more into that moderate level. But to the question, the diagnostic tools show more of a structure, not so much more of that function, which is what we're seeing, that the trauma that the brain sustains in these motor vehicle accidents is maybe more of the functional relation. So you can still have integrity of structure within the brain, but you can still have loss of function. Some of the things that go on aren't going to show up. There's a huge biochemical dysfunction that kind of goes on. Neurotransmitters are going to be disrupted. The synapses are going to be disrupted. How a neuron communicates, which is electrical communication, can be disrupted along that axon. Swelling, edema, those types of things. And you get just basic inflammation. It's just as if you stub your toe or you hit something, you're going to get some type of protective inflammation that can be there too.
So kind of like the chemical soup that the brain sits in is now too salty or too sweet or too sour or too. So it's, I mean, not that we're eating brain soup,
Right.
but
Not for dinner tonight, maybe another night.
but just metaphorically speaking, like the wiring of the brain can look the same on imaging, but like the soup that it sits in could be completely disrupted.
Ah. So when somebody starts to have that soup that's disrupted in their brain, it doesn't show up on some sort of imaging. They go to the ER. That's when they start to have other symptoms that still stick around, though, right?
Well, typically at the time of injury, we might not see a lot of neurological, those sequelae kind of quite develop. Is what we're seeing is following concussions, mild TBIs. I wish we would kind of sometimes drop concussions, but I think mild TBI is more accurate. But that we won't see a lot of that sequelae until maybe about 14 days post-injury when things start to settle. Maybe some of the inflammation is settling, the swelling has gone down. And again, it depends on sometimes the severity of that impact. How impulsive was that acceleration and deceleration? Just from a car being hit, I think the last, as small as 9 miles per hour, you can see. Now, granted, if the impact is greater, we're going to see a higher acceleration and deceleration. So the more that impact, then we can possibly see some things on those diagnostic tools. But right now, we're not seeing those. So, PET scans might show them, the SPECT scans might show, neuropsych evaluations, those are more functional related.
So PET and SPECT are just really high sophisticated kind of imaging. It's not something you would find in the emergency room. It's kind of a specialized test that would be ordered. But the neuropsych testing is what?
That's more function, so it'll go through. What we're seeing is, there's a certain percentage, and it's a high percentage in my book. We'll see about 30% of those individuals who have had a mild TBI, 30% will have permanent impairment of some sort, and we don't know what that is.
And there's nothing we can do about that.
No, I think there is.
Ta-da!
It's just we're just not getting the appropriate neuro rehab up front. It's not about just taking the medications for pain or the headaches. It's actually doing some neuro rehab, getting those neurons to reconnect, and we can reconnect, and we can actually develop new neurons.
And this is what I really appreciate, because we share a same philosophy. A lot of people go to the emergency room or go seek health care, and the assumption is that the objective tests out there, like the MRIs and the CT scans, are what are going to identify the problem. And once you know that, then you know what the answer is. But the reality is that there's so many conditions that both of us treat where it's a subjective issue. It's not just the findings on the imaging, it's actually what that person is experiencing. And you really can't tease that out until you get to know that person, interact with them, and know that you're not just treating the symptom. Like, yes, you and I can both treat the symptoms and just minimize the pain or minimize the discomfort from that traumatic brain injury, but it's really a matter of understanding the root causes, the fundamental underlying problems that are related, and starting to work on addressing those, not just kind of numb the symptoms and brush it under the carpet.
That's a good point, yes. Very much.
So it sounds like a lot of those people that have ended up thinking they're permanently disabled, they just never had a very good quality exam. They just thought the CT and the MRI that's all they need, and this is me forever. When actually, if they had a quality examination and then some sort of quality care afterwards, they might actually get some good recovery out of that.
Yes, they would. And don't get me wrong, there is a high percentage that do recovery within that 4 to 6 month period of time.
Just on their own.
They can. It's just, unfortunately, I'm too scared to be that one that falls in the 30% that don't.
Right, because you can't tell, right? I mean, if we had a perfect metric to say, okay, these 3 out of 10 people are not going to recover, and this 7 out of 10 would, then it'd be easy. But if we don't have that kind of a lens on the subject, then it's what kind of time frame are we looking at? What someone needs to get evaluated and treated?
Well, that's a good point. The brain does have neuroplasticity all throughout our life.
And that means what again for our folks in TV land?
Neuroplasticity.
It's made out of plastic, James. Brains are plastic, and you can melt it down and make a new brain.
That's awesome.
It has an ability to regenerate, recoup, but sometimes it's going to need some extra help. Where we start to tread, and some of the area that we don't want them to is about 4 to 6 months, and then it starts to become maladaptive plasticity.
Meaning,
The neurons aren't connecting the way they need to connect.
so like the plastic's now melted and
Yes.
it's not really
It
looking
is.
like a brain anymore.
And so
And it's soup.
Ugh, stinky plastic burning salty soup. Ugh.
And that's probably where the 30% then come in with permanent impairment. So there is a way to address it, and we just need to start sooner rather than later.
I imagine age has something to do with that too.
You know, you would think,
Huh.
and some of the studies that are out there, we actually did not find a huge difference between the ages. The brain was still able to regenerate, still regain resumption of functions. And does it happen as quickly as if we were in our teens or 20s and our 30s than 50, 60, and 70? But the process was still the same. There was not a huge deviation in that correlation.
Yeah, because I often get that question. Somebody comes to me and they're, an older individual, and we're looking at their joints and trying to regenerate structures within the joint to reduce the pain. And they always ask me, well, can my body regenerate? And I always have to tell them, well, do you grow hair? Do you grow skin? And if you're able to do those things, then your body is still regenerating. So whether we're talking about the brain or we're talking about the body or the joints, there's always the capacity to get better. It's just a matter of it might be slower.
That's correct, but we do, yes.
Yeah.
So people who've been through some sort of injury, and it's been, let's say, about 2 or 3 months, and they're still having these persistent symptoms, maybe loss of memory, a little bit more anxiety, depression, things like they're forgetting things all over the place, maybe balance issues. Those are the people who we should really start to consider that they need a little bit more thorough examination, right?
Yes.
Okay.
Yes.
And we're not
so-
just talking about car accidents, right?
Mm.
Not just car accidents.
Okay.
We're leading off of whiplash, but
Yeah.
which, yes, we're going to get a brain injury probably out of a motor vehicle accident with
More
the whiplash.
likely, yeah.
More than likely. It's hard not to not sustain that. But yes, any type of trauma that the brain has sustained, in gunshot wounds,
Sports
anoxia,
injuries.
hypoxia,
Everybody talks about brain injuries with football,
falls.
falls.
And falls is the leading cause of brain injury
Yeah.
at present.
Oh, yeah, I forgot about that.
Yeah, I can't tell you how many times we hear people say, well, I had a fall. Did you pass out? I don't know, maybe for a few seconds.
That's not good.
I'm like, wait a minute.
Was that before or after you were on the ground?
Right.
Now, these are important facts.
That's
too.
true, right.
Right.
Before or
That's
after.
a huge red flag when we hear that.
Yeah.
Chances.
All right. So with those people, we've already figured out which type of people probably need to get some sort of more expert examination. So let's say they've been examined, they definitely have some sort of TBI, and they've got some of those symptoms. Well, then what? What do they do after they've already been shown that they have some of these big long-term impairments? They
Well-
just sit around, right?
No. hopefully, they would be referred to a company that specializes in brain injury, and where they would come and get further evaluation from each of the disciplines: physical therapy, occupational therapy, speech therapy. They may even need counseling. I can't imagine having had a function, knowing that you have that function and not being able to do that again. I can't imagine just the depression or the anxiety and not being able to do the things that you should. And with those mild TBIs, I always want to equate. It's almost like that tip of the tongue. You know what it is that you're supposed to do, but you just can't get there. And so following through with those tasks, again, is it the memory and the organization, like you said. So those are a lot of the skills sets, at least with my company, that we can help work on with individuals when they still have those symptoms. And we're probably talking, we've actually labeled it post-concussive symptoms, and that usually, again, at that 4 to 6 month period.
Right. So you know what you need to do, you just can't. Ba-dum-bums.
So it's kind of like a brain fog. It feels like you're,
So for those patients, they'll be getting some therapy to make physical therapy, as an example, to improve their coordination and balance, occupational therapy so they can handle things around the home, improving their just quality of life, daily activities, speech therapy so they can speak better than he just demonstrated right there, and then even some sort of cognitive therapy and psychological care so that they can start to adapt to these new changes, and all of that gets put in together, and that's what these people with these more long-term impairments need, because the brain got bonked, and the brain controls all of that.
Yeah, it does.
So you need all of those things to help the brain get back to the best function again.
Right.
Did I miss something?
No, you did not. You really summed that up really well. you really did. The brain.
I studied.
I still ask the question, what is it the brain doesn't do? I'm not sure yet.
Me neither.
It's quite an amazing thing.
Cool. So what else do you think the people who are watching this, who might have a loved one who has gone through this type of injury, needs to know about this type of condition, the type of care that they need, who to seek, what to do about either the pain component, any of those?
Right. And there are resources. The Brain Injury Association of Kentucky is a good resource too that can provide a lot of information just in who's on the website and where they might be able to get some local. I think looking at maybe a care of a physiatrist, which is more specialized within the neuro field. You can have a physical medicine and rehab doctor. The challenge is getting somebody maybe more focused in a neuro as opposed to the ortho aspect. We get a lot of the ortho get treated before the neuro portion of it. So a physiatrist would probably be where I would recommend somebody would get under the care for that. They're going to be more about the rehab component for the individual. Hospitals, brain injury, the acute outpatient could be very helpful too. It's seeking, again, some type of counseling, a psychologist, somebody who's very knowledgeable in the brain injury, could be very helpful.
Yeah, and where we stand is on the ortho side of things. We want to try to help people recover from these kinds of traumas and injuries, but we definitely like partnering up with folks that are well versed in the neurological aspect. Definitely, it's a great partnership.
That is a good point. I don't think you can tease out the ortho and the neuro all the time.
They're going to happen at the same time, definitely.
Yeah. And it's just good that you guys at home make sure your providers know that if they've got big pain, well, what do? Obviously, come to us too. But also, what's good about us is we're screening for these types of things. If they've fallen, they've had a car wreck, any of those types of things. If these patients are having these protracted symptoms, well, somebody's got to be thinking about these types of things so that they can get the appropriate care for that long-term rehab if they need it.
Yep. Yes.
Oh, good. Glad you agree.
We always value each patient as an individual, and in that manner, we also honor the uniqueness of each patient in developing our own treatment plans around the conditions that they face. That's what we do here at Wellward, and why we bring this 50 Shades of Pain show to everybody is to try to empower you with the knowledge that you need to feel more in control of your own health and well-being. So you can find us. We encourage you to join us on wellwardmed.com or here on our Facebook or YouTube channel. We've got a lot of different social media access points. I imagine you guys have the same?
We do. Yeah, there's a wealth of information just at neurorestorative.com.
Great. Well, thank you so much for joining us this week. We hope to have more special guests like this in the future. Please feel free to comment and give us feedback. And next time we'll see you a week from today, Tuesday at 6:30 on what are we talking about?
We're going to be talking about headaches and everything you guys need to know to take care of those at home.
Thank you, everybody.
All right. Thank you.
Thank you.